morning, everyone, and thanks for inviting me to do this case presentation. So I'll be doing a presentation on hepatocellular carcinoma. So I have no disclosures. So my patient is Mr. E.A. He's a 43-year-old male who presented with a 3-week history of abdominal pain. At the time that we saw him, he was already diagnosed with chronic hepatitis B infection. He already had diabetes and also had hypertension. And he presented with the right hypochondriac pain. The history was unremarkable for melena, hematemesis, jaundice, or pruritus. But this patient's past medical history, he had been diagnosed with chronic hepatitis B for 12 years. And initially, when he was diagnosed, he had a normal liver function test and an undetectable viral load. And at the time, the primary care physician decided not to start him on any antiviral therapy. But he decided to monitor the patient with liver function test and then viral load routinely. But he failed to put this patient on HCC surveillance with either ultrasound and/or alpha-fetoprotein. So in 2014, this patient had a normal liver function test, but his viral load had gone up to 20,618 international units per mil. So at the time, the physician decided to do a liver biopsy, which was done, and that showed fatty liver. We didn't get the documentation on the grade of steatosis. And then in the same year, 2014, this patient was later diagnosed with diabetes and was started on oral hypoglycemics, but at this time, still, this patient was not started on any antiviral. And then a year later, this patient was then diagnosed with systemic arterial hypertension and was started on antihypertensives, but not started on any antiviral. And the patient claimed that through divine intervention, his viral load returned to normal without any therapy. So at the time we saw him, he was only on Novas, 10 milligram daily, and then Galvus-Met for his diabetes. Family history, the mom was actually, had hepatitis B, and he had only 2 siblings, 2 sisters, and they were all hepatitis B positive. Social history, he took significant amount of alcohol. He was doing about 40 units of alcohol per week. And then after the liver biopsy, he decided to take occasional wine because he was advised to stop taking alcohol. But he never smoked and was married with 2 children. So on physical examination, at the time we saw him was aneteric, very stable, had no stigmata of chronic liver disease, abdominal exam, soft, no organomegaly, no ascites noted. His random blood glucose at the time was actually 23.5 millimoles per liter. So an initial diagnosis of Curie hepatocellular carcinoma was made. He had risk factors, chronic hepatitis B, the chronic alcohol use disorder, the metabolic dysfunction associated steatohepatitis. So his initial hemogram, the platelet was already low. He had platelet of 127, normal renal function, glycated hemoglobin of 9.1%, but the alpha-fetoprotein at the time was just 2.35. His liver function already had elevated transaminases, ALT, AT, AST 56. The GGT was 860, ALK-phos 635. Albumin was already low, an albumin of 34.8. INR at the time was 1.3, and it was E antigen negative chronic hepatitis B patient. The hepatitis delta antibody was negative. Viral load was undetectable at the time, and then HIV and hepatitis C were negative. So the initial endoscopy done, he already had portal hypertensive gastropathy, and then isolated gastric varices type 1 and 2. Initial ultrasound was said he had liver cirrhosis, but no ascites. And then we decided to repeat this ultrasound a week later, and the second ultrasound rather picked up numerous hypoechoic nodules suggestive of hepatoma. So a triphasic CT scan was ordered, and the findings were consistent with a multifocal hepatocellular carcinoma with almost complete thrombosis of the main portal vein and some of its intrahepatic branches. So we made an impression of a diagnosis of liver cirrhosis. At the time, the Child-Pugh class was A with portal hypertension with multiple risk factors, as we've already alluded to, chronic hepatitis B, the chronic alcohol use disorder, and the metabolic dysfunction-associated steatohepatitis. At the time, his ECOG performance status was 1, so we thought he was in BCLC stage C, hepatocellular carcinoma. And then we referred him to see the oncologist for further management. There, he did a liver biopsy, which confirmed hepatocellular carcinoma. So patient was started on tenofovir at the time, 300 milligram daily, and also started on carvedilol for the portal hypertension. He was still continued on his anti-diabetic medications and antihypertensives. So upon review, the oncologist decided to start this patient on atezolizumab at 1,200 milligram with bevacizumab, 15 milligram per kilogram as IV infusions every 3 weeks. So after the first cycle of the atezo-beva, this patient had 2 episodes of epistaxis, which had to be managed. And then patient also noticed at the time that he was having gradual distension of the abdomen. And then when we re-examined him, this patient had developed moderate ascites. Yes, so after the 3rd cycle, the liver enzymes now became markedly elevated. You can see that the AST had doubled from its baseline, the ALT just marginally. Now the GGT were in the thousands. The alkaline phosphatase also almost 2,000. The albumin had dropped, and the total bilirubin, surprisingly, was reducing. So at this time, the cycles were still continued. So cycle 4 and 5, the oncologist decided to now suspend the atezolizumab and just continue with just the bevacizumab. And patient was then started on steroids because we suspected an immune-mediated liver injury at the time. The alpha-fetoprotein was now 14.02, and you can see from the liver function that when the atezolizumab was suspended, the liver enzymes, the GGT started reducing. The ALK-phos also just marginal reduction. And yeah, so for cycles 6 and 7, the oncologist decided to reintroduce the atezolizumab, and we can see that the enzyme started going up again. So for cycle 7, we decided to check the hepatitis B viral DNA, which was undetectable before, and now it was now detected. We had about 45 international units per mil. So at this time, by cycle 8, patient already had jaundice. So that atezolizumab was stopped, and patient started on steroids again, and then an abdominal CT scan was ordered at the time. So this time, the repeat CT revealed an ill-defined solid lesion in the liver hilum and trigone ducts, which measured around 3.6 by 3.4 cm. Patient also had multiple liver mets as well, with complete thrombosis of the portal vein. And there were now retroperitoneal and perihilar lymph nodes metastasis, and also the ascites that was noted. So the radiologist then findings suggested that it may be a cholangiocarcinoma. So we had some conundrums with this patient because both set of CT scans were then done in the same center. Patient had multiple risk factors for the hepatocellular carcinoma. A liver biopsy was done at the time, which clearly showed hepatocellular carcinoma. And then we thought he had clearly failed the atezolizumab because there was progression from the liver cancer. So we're wondering if this could be a combined hepatocellular carcinoma with cholangiocarcinoma. So just something, some small literature on this. So usually combined hepatocellular and cholangiocarcinoma is a tumor that exhibits both hepatocytic and biliary differentiation. The incidence of combined hepatocellular carcinoma and cholangiocarcinoma among primary liver cancer lesions is reported around 0.4 to 14.2%. It's a rare entity with high incidence in males with Asian and Pacific background. The risk factors are comparable to those of HCC alone, and prognostic influences include sex, tumor size, and therapy status, with poorest prognosis in patients who do not receive surgical resection, radiation therapy, or chemotherapy. And then what was of note was that the morphological diagnosis is still challenging for radiologists and pathologists, especially on biopsy specimens, and that resection with lymph node dissection was unfortunately the only curative option for patients with this condition. So patient was then started on sorafenib at 200 BD, and we consider the GGT now came to 249, ALK was reduced, ALT, there was some slight reduction, and the AST as well, with bilirubin around 235. Unfortunately, like most of our patients, this patient died some months later. So lessons learned from this case, as we said, the mother and two of his siblings were all Hep B positive, so it emphasizes the need for prevention of mother-to-child transmission. This patient should have been started on antiviral therapy very early on in the course of the disease. HCC surveillance was not done for this patient, which might have picked up this lesion at a very early stage, for which we could have offered curative management. And then there's always a controversy about the role of liver biopsy in HCC management, and then also highlights the need for a multidisciplinary approach in managing these patients. And then we also have to be aware of the immune-related adverse events with the immunotherapies that we have. And then also, notably, non-response to atezolizumab, and some of the studies I came across, non-response was almost more than 55% in an Indian study that they did. And one of the key things that they noticed was diabetes was one of the few diseases that actually cause non-response to atezolizumab. And then the fact that we need the LIRA system of reporting for our CT scan images. Thank you.